Great. Thank you, Jennifer. Thanks, Abba, and thanks, Sahar, for having me here today. And it's certainly a privilege to be here amongst SCAD enthusiasts, both from the physician side and also from the patient side, and from patient advocates as well. I want to take this opportunity to really thank you as patients and patient advocates for your time, your volunteering your time and your effort, being subjects for SCAD research. And without you, a lot of our findings over the past 5 years would not have come to fruition. So what we've learned so far really is thanks to your commitment and participation in SCAD. Thank you so much. So I've been asked to talk about exercise and activity for SCAD. And even though this is an area of great interest, there is not a lot of data supporting that. And so I'll give you our perspective and what our patients in Vancouver are asked to do. So what I thought I would start off with is to give you an overview about the type of patients who get SCAD and how we tailor exercise therapy based upon this different profile from what we're typically used to, right, in patients after a heart attack, which generally we think about men, older men with atherosclerotic disease, and obviously this is not a population that we deal with. So when we look at who develops SCAD, so typically this is the young to middle-aged group of women. And if you look at as a cause of heart attack, young women less than age 60 who have a heart attack, about 25 to 30% of times is actually occurring in women due to SCAD. And in pregnancy-related, you've heard it's about 43%. So what about the age demographics? If this is a bell curve just showing the age groups, for distribution for patients who get SCAD. So 91% less than age 65 and about 22% over age 60. So again, this is not just a young patient disease, it's a young to middle-aged patient disease, although yesterday or 2 days ago, I saw, 3 patients, 70s, 81, 79. So it falls, a bit more off to the right side of the bell curve here. But the majority of our patients are somewhere between 40 to 50, the mean age being 52. 90% are women, and these women are otherwise fit and healthy. They have a BMI of less than 25, right? And if you look at distribution, the majority are Caucasian, 80% or so. But we have other races who are involved as well, and there might be issues with language barriers in some of the South Asians, for instance. And if you look at other important risk characteristics, we heard about depression in about a quarter of our patients and anxiety, at least 15% or so or more from others that you heard from Katie earlier today and Tina. So these are important considerations in terms of managing them post. If you look at emotional and physical trigger in our series, where we prospectively ask these patients, do you have emotional stress before you come in or physical stress? We're identifying about 50% have emotional triggers and about 28% have physical triggers. Some of the other series I listed out here have perhaps lower proportion, but primarily because they're not prospectively asking these questions. So what are some of these emotional triggers you've heard earlier from Tina and from Katie? So emotional triggers can be from stress at work, relationship breakdown, intense arguments, death in the family, etc. These are some of the really major triggers and major events that occur. These are typically within the week prior to the event. But what about physical triggers? So here in the 280 patient cohort we presented not too long ago, physical stressors in about 28% of these patients. And what are these? A lot of folks have participated in isometric types activities or weightlifting type of activities and lifting more than 50 pounds in about 7%. Aerobic physical activity is about 17%. So maybe just a show of hands here of those who've had SCAD. How many were doing aggressive physical exercise within the week before? This is way more than 28%. All right, so clearly, when we're educating our patients after a SCAD event, we have to take that into consideration. So how do these patients describe these? So a third describe these as unusually strenuous. A third just recently started training. And about half thinks that these activities actually triggered the SCAD events. So let's keep that in mind. What is the other important factor to keep in mind? Well, long-term cardiovascular outcomes. We talk about recurrent SCAD being quite common and recurrent heart attacks. So recurrent heart attacks about 20 to 30% over 5 years. Recurrent SCAD about 15 to 25% over 5 years. In our series where we have median follow-up 3 years, average yearly rate of heart attack is about 5%, average yearly rate of recurrent SCAD about 3%. So that's an easy number to remember. And how do we minimize these values over time? So let's talk about cardiac rehabilitation. So what is cardiac rehab? So cardiac rehab is an outpatient chronic disease management program that essentially contains 5 key components. So we have to address risk factor, we have to address exercise, nutrition, patient education, and psychosocial counseling. And who needs cardiac rehab? Clearly patients after a heart attack needs rehab. And almost all patients with SCAD present with a heart attack. So based upon the American Heart Association guidelines and ACC guidelines, well, this is a class 1 indication, meaning you should do it because we know the data supporting that is very strong. And so in women itself, we know that there are benefits to cardiac rehabilitation. So what are these benefits? They're both physical benefits and psychological benefits. So physical benefits includes reducing your hospitalization in the future for cardiac events, reducing your mortality, your morbidity in terms of other diseases, your frailty, improving your symptoms in terms from chest pain, angina, or chest discomfort, you want to call it, microvascular disease, which can result in a lot of these chest discomfort, and improve your functional capacity. Psychologically, it reduces your anxiety and depression and stress level, improves your patient-physician relationship, which is what we all endeavor to achieve, and improve your medication adherence and social support. So there are clearly benefits to cardiac rehab in women, but there are a lot of challenges along the way in terms of referral, enrollment, and adherence to cardiac rehab. In fact, less than 20% of women participate in cardiac rehab after a heart attack. And that's a miserable number. So what are these barriers? Let me just read them out. You might identify with that. Low physician referral rates. Who has been referred to rehab after a SCAD event? Okay, this is a minority. This is less than 10% of the crowd here. So lack of awareness among women about their coronary disease, low education, low social support, psychological stress, financial barriers, you got to co-pay. You need to take time off from work. A lot of women are full-time, mothers or full-time job. They have to look after the parents, for instance. There might be language barriers, cultural differences, geographical inaccessibility, and lack of transportation. And then particularly in women, we have other specific needs. Women prefer a wide variety of exercises. They don't necessarily just want to do exercise on treadmills or elliptical. They prefer dancing or yoga, other forms of exercise. And there is a fear component, an embarrassment component that we don't want to exercise in front of other women or men who might be a lot more capable in those realms than we are. So they're hesitant to exercise in the mixed sex settings. And so women-only programs may actually allow greater adherence to these programs. And we know that if you do not adhere to cardiac rehabilitation programs, that you don't do as well. So there is a 1% decrease in mortality with each cardiac rehab session attended. And there's a 10%, every 10% increase in your attendance was associated with 4% reduction in death or hospitalization at 2 years. So clearly, once you enroll in the rehab, you should try and participate and finish your rehab program. So now come to the challenges of rehab for SCAD patients. So when we started our program with SCAD and got interested in SCAD, it's somewhere in the range of 2010. And we were fortunate because we have a large group of local patients in Vancouver. And because of the large group of patients we see, we can identify what other resources that they would require. So I wrote this paper a couple of years ago, and I would read this out to you because I think it was pretty well written, and perhaps you can identify with that. I'm going to read it out because I was just reading it last night. I said, you know what, I should just read it word for word. So our program is the first SCAD-specific rehab program designed to address the physical and the psychosocial aspects after a SCAD event with support from a multidisciplinary cardiovascular team. We address exercise rehabilitation needs, but also the emotional issues often encountered by SCAD survivors, and both are important challenges. So after a SCAD event, patients are typically distressed, with little understanding of the disease process, uncertain why they suffered the condition, and have limited resource from standard healthcare professionals because SCAD is a poorly understood and infrequent condition. Furthermore, most SCAD survivors are afraid and reluctant to start physical activities after SCAD, and their physicians are often also uncertain if they can resume exercise because of lack of published literature and recommendations. In addition, there is a lack of peer group patient support because most SCAD survivors find themselves isolated geographically without other SCAD survivors in the vicinity. Social media and online support groups have improved the situation, but there remains a lack of in-person, peer-to-peer interactions in local communities. We specifically designed our SCAD cardiac rehab program to improve our patients' emotional and peer group support, education, and understanding of the disease and exercise rehabilitation. Does that sound? Sadly, 2 years later, we still have the same challenges. Okay, so this is how our program is constructed. So we have a routine pre-program interview, consultation, and physical examination. This is done by our case manager, which is usually Tyra, and our cardiac rehabilitation cardiologist. And so we look at the patient demographics, their symptom status, their medications, their lab results. They all have baseline depression scores and physician Q score 9 administered. We've reviewed the medications. They're often coordinated with our SCAD clinic. And so these are a group of individuals in the multidisciplinary team who are involved: cardiologists, nurse, kinesiologists, fitness instructors, social workers, psychiatrists, dietitian. This is our structured exercise training. So everyone gets a treadmill test before they start the program. And we have an hourly, weekly exercise class, and patients are encouraged to join 2 more sessions during the week. So this 1-hour weekly class consists of 15 minutes warm-up, 30 minutes exercise on the aerobic machines, and 15 minutes cool down. And this is our target heart rate that we prescribe during the exercise program. So we look at your heart rate reserve based upon your treadmill test that you did, and our target exercise heart rate is between 50 to 70%, sort of depending on your ability to exercise beforehand. And we monitor your systolic blood pressure during exercise and try and keep it less than 130. Exercise is adjusted to keep the upper heart rate target to achieve a rating of perceived exertion, and you might have heard of that, a scale of 1 to 10, somewhere between moderate to somewhat difficult, and I'll show you that later. In terms of resistance training, we really try and minimize excessive weight lifting more than 20 pounds. So during our program, we say less than 20 pounds. And usually when they do resistance training, we encourage light weights, 2 to 12 pounds, and you want to have more repetitions rather than increasing the weight and progressing with strength gain. And outside of the formal program, the patient can participate in the regular open gym whenever they want. So patients are regularly assessed by our case manager for additional psychosocial support. We have referrals to psychiatrists and social worker as they require. There are sessions, educational sessions about mindful living and about cardiovascular disease and about SCAD specifically as well. And having this available every Friday, which is our SCAD-specific rehab, allows our patients to have in-person peer-to-peer interaction. So we published the first 70 patient results about 2 years ago now. So the first 70 patients, the mean age was 52. You can see they were all women here. They're all relatively healthy ahead of time. So our program is 6 months. The mean duration of participation is 12 weeks because keep in mind, most of our patients are active and they're working. And so 40% completed the entire 6 months. 70% completed at least 1 month. And I always tell these patients, even though you live an hour and a half away, come join us for a month so we can teach you how to do this. So when you go back to your community, you don't have to do the commute anymore, but at least you can still have benefit from the education that you receive here. 29% had social work referrals, 27% had psychiatry referrals, and we had mean duration of follow-up of almost 4 years for these patients. What we found was that a lot of patients had chest pain at the beginning of the program, 63%. At the conclusion of the program, about half had chest pain. And we found that their ability to exercise increased with our program from 10 METs to 11.5 METs. We found that their depression score improved after participating in our program. And we found that they're pretty good in adhering to medications, especially beta blockers is about 85%, and aspirin about 92%. And very importantly is the cardiovascular outcomes. With this program recommendation of exercise that we have, it is actually very safe. In fact, although we can't compare oranges to apples, if we compare our SCAD cardiac rehab cohort to our non-rehab cohort who are SCAD patients, we found that actually their major adverse cardiac events are actually lower, having participated through our cardiac rehab program. That means our program is actually not risky or dangerous, it's safe and might be protected. So this is the standard sheet that our patient would get. And you can see here, the RPE, the rating of perceived exertion scale of 0 to 10. And then the gray is where we want our patients to be. So for instance, here, a patient who has done their treadmill test beforehand, she accomplished 13.4 METs. We look at her maximum heart rate. We, calculated between 50 to 70% of that heart rate reserve. And this patient has a target heart rate of 112 to 122, so we list it out for them. We advise them, when you're exercising, you want to be able to talk enough to carry on a conversation, exercising within your target heart rate. And with the RPE somewhere between 3 to 4 for this patient, we advise they should do this at least 4 days a week. And the key of things to avoid are in the box in the middle here. Avoid isometric exercises. Maintain movement throughout exercise, do not hold breath, and lift, push, pull sort of strength less than 30 pounds. And so these are what the worksheets the patients would get to go home with. Now we know that unfortunately this is the only SCAD specific rehab that I know of in the world. So obviously most patients outside don't have the privilege of being in the program like this. So most patients are standard cardiac rehab, or you have to exercise on your own. So what are some of the other recommendations that I can show you? So this slide here shows you metabolic equivalents, or MET. That basically, 1 MET is the energy you expend when you're sitting there doing nothing. So you want to exercise to sort of moderate to vigorous, low vigorous level. So that's between 3 to 8 METs. So what are these activities for patients getting out there to start exercising? So in terms of sports and leisure, it will be doing volleyball, golfing, dancing, backpacking, basketball. That's usually less than 8 METs, which is doable after a SCAD event. Soccer, running aggressively, probably not. And other forms of exercises, so Pilates, walking 4 miles per hour. I'll talk about weightlifting later. Swimming front crawl, those are acceptable. But more than that, boot camp, running intensely, probably not. So these are some general guidelines. In heart rate zones, if either you use your percentage of your maximum heart rate or percentage of your heart rate reserve, aim for somewhere in a moderate range, less than 80%. And this includes, you can talk, but you can still breathe through when you're exercising. So there are 4 types of exercises, really, that's been categorized. And so I'll address each one of these for SCAD patients post. So obviously, flexibility types of exercises and balance exercises is a no-brainer, is not a problem for SCAD patients, okay? And we obviously want to encourage you to be flexible and gain your balance. And most yoga are fine, but if you start asking me about hot yoga, then most of us would say probably not. But generally, Pilates and most of the forms and positions with Pilates are fine. What about aerobic exercises? Actually, we highly encourage aerobic exercises with the caveat that, with the caveat that you get to think about your rate of perceived exertion. So this is a subjective scale of 0 to 10. So anything less than 6 will be acceptable. Also, if you want to use your Fitbit, other heart rate monitor, well, you can calculate yourself what is your maximum heart rate, right? So less than 80%, definitely. And so any of these aerobic exercises are fine. The biggest question that we have is strength training. And that's a plus minus because, we want some strength training, but we don't want excessive. Everything here is about moderation. So, for instance, weightlifting, we'll talk about concentric, eccentric, that type of weightlifting and isometrics. Then we'll talk about plyometrics, calisthenics, and sprinting. So So strength training. So number one, concentric and eccentric. This is like using a barbell, right? So concentric meaning you're bending, you're contracting your muscles, and then eccentric means you're relaxing your muscles. So that's a typical weight training that we think about. So things like bench press, deadlifts, squats, kettlebells. Well, I tell you, sometimes we tell our patients don't do these and they don't listen to us. But I think if you want to do these, just be mindful about the weights. So again, be mindful. For men, we would generally say, okay, less than 50 pounds. But if a man had a SCAD after he raised 50 pounds weights, I would say, well, you should do less than what provoked your SCAD. It's common sense. For women, we generally say less than 30 pounds. Okay, initially maybe less than 20 pounds, but after you get used to some level of exertion, after that, 30 pounds is our top limit. What about isometrics? So isometrics are exercises done without changing the length of the muscles, and so it's a static position. So what are these different examples of isometrics? Forearm planks. Who likes doing forearm planks? Actually, I do it too, but probably SCAD patients shouldn't do it, because if you think about your weights that you're distributing amongst your four limbs, it's at least half in your forearm. And so I generally don't advise forearm plank. Definitely not side-arm plank, because I think that's more strenuous. What about isometric push-up? I definitely say no. Hanging is a fair bit of, challenge when it's getting up there, so I'd say no to that. Isometric shoulder press, it depends on the weight that you're using. Usually that's acceptable. Shoulder rotation against wall. Obviously, if you don't want to bear down so much, you're forcing yourself very intensely, that would be a no, but generally light pressure, that's acceptable. This is warrior position, generally helps with balance. Bridge, that's fine. Wall sit, I really like, that's not an issue. Static lunge, that's not an issue. Weighted calf raises, not an issue. Squat hold, not a problem. Isometric, this is wall push-up, not a problem unless you're pushing yourself crazy, right? So again, everything in moderation. Isometric bicep curls, that's acceptable. Keep it to less than 30 pounds. Probably less than 20 pounds if you want to do multiple repeats. Hip abduction, chest squeeze, those are fine. So again, this is moderation. Think about the maximum weight that you're exerting and try and breathe through those activities. What about plyometrics? I had to learn this term. So this is jumping training, where the muscles exert maximum force in a short interval of time. So when you hear about interval training, this is usually a no-no. So this improved performance and speed. This is like squat jump. This would be a no-no. What about calisthenics? So utilizing your body weight for resistance for some of these pull, pushing, bending type of activities. So things like muscle ups, it's a bit much if you think about your whole body weight. Pull-ups, nope. Chin-ups, nope. Squats, okay, but not squat jumps. Push-ups, I not recommend that. Front lever, back lever, are we trying to be gymnasts? We're not, so let's just not even think about that, seriously. And dips, do we really need to do that? Burpees, I actually had a patient dip burpee and then she had a SCAD, so I don't quite recommend that. So certain calisthenics you may think about, but again, think about the ways that you're doing that. I hear this term a lot, high intensity type of training. 2 days ago, a patient came, she had a SCAD after going through Orange Theory, okay? And I've other patients in the past from CrossFit. So if you think about their model for these exercises, it's really high intensity interval training, and we're really getting really high bursts of activity, and then complete rest. I think if you don't have cardiac disease, this is a good way to burn energy and have after effect burn. But for SCAD patients, this is not recommended. So definitely I would not encourage that. So in summary, exercises post-SCAD guidelines, be sensible, listen to your body. And I always say think Zen. It's very important, even for non-SCAD people like us who are always worried we might get SCAD ourselves. And just do not bear down. Think about activities that you need to Valsalva. If you're carrying a grandchild who's 30, 40 pounds, well, you shouldn't do that. And so avoid these excessive weights. Think about the rated perceived exertion level, max of 6, and avoid competitive sports. Avoid the marathons, Ironman, things like that, high intensity sports, avoid that. And definitely join a cardiac rehab program. And I'll protocol algorithm is published, so people can refer to that. So in summary, strongly encourage cardiac rehab after SCAD. You need to understand why your patients are not going through rehab, and you might want to consider alternate modes of cardiac rehab, be it internet-based or telehealth. SCAD patients have a different condition, and their rehab should be tailored, and we need to incorporate psychosocial and peer group support and education. I'm going to take this opportunity to just promote the Vancouver SCAD conference, which is coming up in September 7 and 8. Hopefully at that time we'll still have great weather in Vancouver. And this is a program that's basically 2 days that is not only for patients but also for physicians. So we have a whole group of faculty, about 40 faculty, including many of the members over here. And so we'll give you a great update on how to manage SCAD. And I would encourage you to encourage your family physicians, your healthcare providers to attend. As you know, dissemination of knowledge is key. We've gotten some information about our background of research, but we need to educate the frontline physicians, the emergency doctors, the GPs, the internists, the general cardiologists. So this program is for all healthcare professionals, nurses, and patients. And then we have a 5K run as well after that to raise funds for research and raise awareness for research. So do join us in September. Thank you.